Thank you, everybody. So we're going to start the next session now, where we're going to look at individual tumour types, starting with sarcomas and CNS tumours, and then we're going to look at lymphoma, lung and breast cancer. Thank you.
Okay, thanks. Afternoon, everybody. So I'm Paul Roberts. I work in the Leeds Genetics Lab. I'm also an EQA assessor for the sarcoma and CNS tumour EQAs. And my colleague Gavin Cuthbert works in the Newcastle lab. We work quite closely together, so he's going to do a few slides at the end and also chip in partway through as well. So it's a bit of a double act. And Chris, who wouldn't come forward, Chris Wright from Bristol's also going to be made to speak during this as well. Okay, so we've got a limited time, I think something like 15 minutes for each of the 4 sessions. So I may have to cut some of these a little bit really. So scenarios I'm going to look through then. For CNS tumours, we're going to focus mainly on what we do with 1p19q co-deletion, just as an illustration really to build on what's been discussed previously about our strategies towards calling this and some of the pitfalls that could happen. I'm going to use a few examples of sarcomas as well, again, to look at mainly at the break apart probes and what we do with the atypical signal patterns, because these seem to be the things that crop up within EQAs on a fairly regular basis, really. These are the challenges that do get raised quite regularly, and I think it's important to consider what the next action is going to be before we end up over or under interpreting these things. So just a reminder again, hopefully that's nice and big. So 1p19q co-deletions largely in oligodendrogliomas in CNS tumours. So we do, generally speaking, we have a number of different possible combinations we can have here. So the typical on the left-hand side 1 to 2 combination, but because you get a lot of polyploid cells, as we know in CNS tumours, it's not unusual to see 2 to 4 signal ratios and even other combinations relevant to that as well. And because these tumours are quite diffuse, then sometimes it can be quite difficult to find a nice cozy area of the slide to look at with all the cells having the same signal population. So we have to be mindful of that when we're looking at picking out overall numbers of cells and types of cells as well. But there are lots of other signal combinations, and the more advanced CNS tumours can get, the more bizarre the combinations can become, and you can get quite a lot of heterogeneity within an individual tumour type. So just, we've all seen this kind of thing. We've touched on it a little bit earlier about the various combinations you can get. All of these, I would say, are not, or almost all of these are not going to be consistent with a deletion, other than example D at the bottom, where you've got the 3 to 6 copy number ratio there. So that's fine up to this point. And then in terms of definitions as well, again, that's possibly going to vary according to where you're working, really. So we tend to think about the 1 to 2 signal ratio there as the absolute deletion. Any other combination of that 2 to 4, 3 to 6, and as you get higher than that, 4 to 8, etc., is a relative deletion. Any other combinations you get there are not consistent with deletion. So in terms of definitions, again, this is probably going to come up a little bit more when I talk to you about amplifications as well. We haven't really got very tight guidelines that cover all tumour types that enable us to come up with these discrete definitions. We can base these on a number of different publications that are out there, but in terms of putting it all together and all working towards the same principles, I'm not entirely sure if we are all doing that consistently. So certainly in our laboratory, we tend to we adapted the Horbinsky paper from quite a number of years ago now, looking at more than 25% of nuclei with this 1 to 2, 2 to 4, 3 to 6, I've done it the wrong way around there, signal combination to call out as a deleted case for oligodendroglioma. Usually you get far more cells than 25% of them, but there are occasions when, as I say, if it's a more diffuse tumour type, it can be more challenging, so you do need defined cutoffs there. Other approaches that could be taken are to use what's commonly applied in breast cancer for HER2 scoring, for example, and looking at the actual signal ratios. And as you'll see in a moment, sometimes you can have problems with calling deletions here if you're relying totally on signal ratios. So we advocate really that if you're going to be using signal ratios here to call deletions, ideally you need also to have looked at the numbers of cells and run those two things together, certainly with CNS tumours as well. Another thing to mention, which we haven't really got time for, is of course being mindful that the probes we're using are just a bit of an extrapolation really. So yes, we can have consistent results that look like it's equivalent to a 1p19q co-deletion, but bear in mind these are whole arm deletions, and occasionally you may well be finding deletions there which aren't actually whole arm, which wouldn't actually be sufficient to call that as an oligodendroglioma. So sometimes other methods can be better or sometimes necessary to support that, especially if you've got a surprising result. So I'm going to throw 4 examples here of signal combinations that you could find. So again, sticking with CNS tumours, first 25 cells, you've got 1:2 signal ratio, and 75 cells, you've got 2:2. So this is quite diffuse. A lot of normal cells are infiltrating there. If you count the overall numbers, that's 175 over 200. So the definitions I mentioned before, 25% of cells deleted, you would call that a deletion. If you're just working on signal ratio, what do you get with that? You've not already calculated it. Oops. So a signal ratio of 0.875. So strictly speaking, if people are using signal ratios, the cutoff of less than 0.8 is what you'd use to call as a deletion. So that would actually be a false negative if you're relying totally there on signal ratio. This example here then, 25 cells 2:4, 75 cells 2:2, with a ratio of 200 over 250. So in terms of the overall number of cells scored there, those 25 cells would be sufficient. But what about that signal ratio? 200 divided by 250, what that is. So that's kind of borderline. So you're just hitting that 0.8 sphere there. Yes, probably sufficient for you to say, actually, we're going to call that. But just bear in mind that's the same number of cells deleted as in the first example, but because it's 2:4, your overall ratio ends up getting slightly skewed. So this one here, then, as I mentioned before, strictly speaking, if you've got the 2:3 ratio there, looking at signal copy numbers, you wouldn't really be considering that as a deletion in this example. But then if you're doing the overall, counting your overall number of signals, coming up with that ratio, that's 200 over 275. And that gives you 0.73. So with using that method, you would call that as deleted because it's less than 0.8. So that would be a false positive. The last one there, similar kind of thing, but just flip that around a little bit. 25 cells, 2:3, signal copy numbers. 75 cells, 3:5. The overall ratio, 275 over 450. And what does that come to? Again, a ratio of 0.61. So that would look quite clearly deleted if you were just relying on the actual signal ratios there. But strictly speaking, those people are looking at the whole signals themselves would look at those thinking, well, actually 2:3 or 3:5 is not what we'd expect to see with deletion. So it just illustrates some of the challenges that we face within these sort of scoring systems. In fact, I'll skip those actually because I know we've got limited time. I was going to talk briefly about some of the other fish that we do in CNS tumours, and there was a little bit of mention earlier about CDKN2A and the challenges there of scoring biallelic loss when you've actually lost your control probe as well. So how do you know whether your fish has just not worked or whether you genuinely have lost both copies of that chromosome? So instead I'll move on to sarcomas. I've put 5 different scenarios here with sarcomas, building on what was mentioned previously. So these are the kind of things that they don't just crop up in EQAs. We do tend to chuck them in EQAs, but they do crop up in the real life. And I've chosen to use my homemade pictures here because it's always quite difficult when you see things in real on an actual screen. So scenario 1 there, you've either lost your 3' or your 5' signal. We've already seen this sort of picture before. So just a couple of opinions really. If you found this on a break apart probe, say it was EWSR1, what would be the typical course of action if this was the majority profile that you were seeing? So yes, you've got a breaking apart, but you've lost one of your signals. Anyone like to comment? Gavin?
Well, it depends on the mode of action of the gene to some extent.
Okay. Anyone else? Would anyone come out and just call this as right? This is a rearrangement. EWSR1 rearranged, and the report just goes straight out. And it's having a consistent approach really in terms of what we do here, and And it's important, first of all, to look at whether we've lost the 3' or 5' signal. What does that mean with the signal that's remaining there? Could we go in there and extrapolate and think, well, actually, yeah, that looks like that's the part of the gene that we're most interested in terms of the active part of the fusion. But you know, you're hedging your bets really if your report is going out and suggesting that without any other further confirmatory testing. So that may involve another FISH assay potentially, but you might start to get into the realms of more molecular testing, so like an RQ-PCR assay, fusion panel assay, as Chris suggested in my communication with Chris, whole genome sequencing, which would seem quite interesting to use that as a confirmatory test. But you know, even so, I think there's more strings to our bow than perhaps we had 10, 15, 20 years ago as well. So the second example there could be any fish probe that we look at. So we've lost one of the copies of the chromosome we're interested in, of the probe we're interested in, and all we've got is signal loss, and all we've just got is that rearrangement there. So effectively you've got maybe monosomy and the rearrangement. People happy to report that as it is? If that's a typical pattern across the board, would anybody want to do any other confirmatory testing? Probably quite happy with that. I would feel generally it does happen a fair bit anyway, doesn't it, really, in terms of aneuploidy during the course of tumour development. So it's not unusual to see that as long as that separation fulfills the criteria that you have set to call a break apart result. One's at the bottom here, number 3 then, so when you've got a diminished signal, so you've not necessarily got a break apart as such, just one of these signals is consistently smaller than you would expect, so you've lost part of it somewhere. Any consensus on what you might do about that? It's normal. Normal? Any advance on normal?
I think you want to see the normal cells to show exactly the same pattern. Look around and then try and think, is this actually, could this be a small evolution somewhere? You're always hybridizing part of it and you're losing the other. You probably want to confirm by doing something else. I don't know.
Depends. Yeah, it depends what else you're finding there. So if you find, say, if other cells you just see this kind of appearance, then the normal size red and green for both copies of the probe you're interested in. But again, it's just, I'm just trying to emphasize about how sometimes we can end up over-interpreting things, going a little bit too far, thinking, oh, that looks different to what I'm expecting, therefore, is that going to be classed as a rearrangement as such, or do we just let that one go by? Similar sort of scenario here, but instead what we've got is the diminished signal, but you've got that separation. So is that, we'd be quite confident to call that as a rearrangement. Reason why not is there so it fulfills the criteria that we've got. And then again, this has been one, number 5 has been touched on a little bit earlier. So if you've got you break apart probe and you're getting the red and green very close together consistently for one of your signals, but in the other signal you've just got that separation a bit more than what you might be expecting. Not quite enough to fulfill your definition of a rearrangement. You're getting, I usually try to put my finger in there, but that's kind of not quite the right definition. Right? I can get my finger in there, it's rearranged. Basically my criteria, but it's not quite there. This was actually the one on the right. It's created this. But this was an EWSR1 rearrangement that we found in the lab that was rearranged. It was an inversion. There's another part on chromosome 22. I forgot. Was it PASF1? That sound familiar? Everyone's saying no there. I've got away with it. PASF1, definitely PASF1. Yeah. So it turned out we had to use some other methods to identify this, including the fusion panel undertaken by our colleagues in Newcastle. Confirm this unusual, unexpected rearrangement there. We did have a feeling that yes, there was something unexpected here, but again, it's so tight. So it just shows how some of the dilemmas that fish can create for us. It's just it's the same kind of thing there. Right, we've only got a couple of minutes to talk about amplification. You'll probably be here all day. Amplification workshop. How many people will be volunteering for that? Definitely, that's next Christmas party, amplification workshop party. One of the difficulties I really want to highlight is the fact that there are different definitions that are out there for calling this, and they do vary from one tumour type to the other one. And sometimes it depends what definition we choose to use and why we're choosing to use it. We might use something that works well for lung cancer, and we think, right, we'll apply that to sarcomas and we'll apply it to every other tumour type, or breast cancer, for example. And it's, you can get yourself into deep water sometimes with that. Polysomy as well, those of us that look at tumours on a regular basis will see that polysomy is just part and parcel of what we see in lots and lots of tumour types. Large cells, multiple extra copies of chromosome regions. You can end up, if you're not careful with your definitions, of having total amplification of everything, because you've got 9, 10 copies of everything, and that isn't necessarily true neither. And then just emphasising the importance, really, of us getting that definition correct, because sometimes with something like MDM2 amplification, we are utilising that to help with histopathology to come up with a definition. But also something like MYC amplification in neuroblastoma. It's not really making the diagnosis, but it's helping to guide treatment. So we've got some important decisions to make in terms of what our reports are saying, with the clarity of what we found there. So just at the top there, I put 3 different references which use slightly different cutoffs to call amplification. So I'm going to focus on the Ambrose reference for neuroblastoma. Slightly different to what we're perhaps all familiar with other definitions of calling amplification, where that calls for signal ratio greater than 4 for your test signal versus your control. There we go. So Gavin, you're more familiar with this, with the Newcastle's role with and I guess in terms of the problems this can cause from time to time. How important is it, would you say, to get this right?
Oh, it's totally critical, and that's one of the reasons why we've ended up becoming a neuroblastoma centre. Was the interpretational issues that FISH can give, particularly if it's low-level MYC amplification. So I personally do favour the Peter Ambrose definition in other settings as well. I can talk about that in a few minutes.
How many people apply that definition over greater than 4 to call amplification? Or does most people stick to their cutoff of 2? Not just for neuroblastoma, just generally speaking. Probably come up in some of the other tumour types anyway. Hopefully it'll come up in further discussions then. And maybe when we come to the guidelines, that could be quite interesting. So we've already seen some pictures of this amplification. If it's amplified, I generally find you can't count them. My definition of amplification is not about thumbs and getting them in there. If you can't count the number of signals, then it's probably amplified. If you can count them, chances are it's not. Controversial, but that one at the bottom is the kind of thing you might sometimes get in fatty tumours, as I mentioned, with a polyploidisation of cells, multiple copies of your control, multiple copies of MDM2. If you did any other probe testing there, you'd probably find there's the same number of copies of every probe that you tested. So just throw different challenges in there. Don't think I'll really focus on these. I just thought I'd throw in a few off the wall sort of examples here. So sometimes you'll get things that you're not expecting as well. This was an YWHA FISH test we did a couple of years ago. So you've got amplification of the fusion signal. It also got an additional 5' signal. And then another example here. This was a FOXO1 PAC7 co-amplification. So you can get this in an alveolar rhabdomyosarcoma. So you got, and these are the days when we used to look at metaphases actually. So there you go. So a nice little illustration, double minutes, showing the co-amplification of FOXO1 and PAC7 in there. But if all you have is just your FFPE, you've just got this smearing of your red and green coming in there. So there are unusual sort of co-amplification things that you can find as well. And those that work with fatty tumours, very occasionally you get rare examples, but it does happen. You've got co-amplification of MDM2 and DDRT3. So we're thinking about two slightly different tumour types here, but occasionally you can get that sort of blurring according to what our FISH results are indicating, and more often than not, you'll find that if you've got the DDRT3 co-amplification, you've probably got some mixed side features within a something like a well-differentiated liposarcoma. I'm looking at you, Anchor, as a pathologist here to validate, or not, as the case may be.
Sometimes it could be the other way around.
Yeah.
The location of the gene.
Yeah.
I think it could be a big site liposarcoma, in the IO3, it comes back amplified in the region that you're not expecting it,
Yeah.
break apart, and then we go into the MDM2 and it's amplified and it's exactly the same.
Exactly, yeah. And you get an ascertainment bias as well. If you were expecting to find a rearrangement, you find that one cell that's broken away from the amplified area, that red cell that you're looking for, okay, that red signal you're looking for, you may end up thinking, yes, that's rearranged, but actually, it's probably not. Right, Gavin's got a couple of slides.
Sorry, this is a bit of a subject change for a second here then. I did a handful of slides and they're not necessarily all about sarcoma, sorry. But it's all about the whole idea of what you do when you've got an atypical signal pattern. It's all the same because it's exactly the same principle. So Polly asked me to put a slide together about KMT2A atypical signal patterns because it's such a high profile probe that we're using all the time. And it's just something that crops up all the time is there a different likelihood of it being relevant if you've got a fusion red or a fusion green? So I mean, I would say that our role as scientists is to understand what's going on with that gene. If we're trying to decide, if we're trying to report whether something's rearranged or not, we need to know what that rearrangement means. So I've just put the link up to the French atlas. We still love the French atlas, yeah, even in its slightly new format of website. It's still an incredibly useful repository for where to go to get an answer quickly. But obviously there are other ways of looking at this. But if you look into KMT2A, all KMT2A rearrangements are in frame fusions of the first bit of KMT2A 5' with the end 3' of another gene. All of them. That's just the way it works. That's the mechanism. So it totally makes sense that that you retain the proximal bit, the 5' bit. Sorry, I flipped into using the word proximal. When you look at a map, that's a cytosol map, but I mean some maps are different of probes. The critical thing is which way the gene is being read. So obviously the arrow there indicates that we're going from 5' to 3'. The 5' bit of MLL, the green bit in this probe, is more significant than the red bit. So a fusion green is more likely to be a biologically significant KMT2A fusion than a fusion red, because the fusion red is the wrong end of the gene. It's the 3' end. That doesn't make sense that you haven't got the 5' bit. I'm not saying that's absolutely always the case, and it's probably a sensible thing to confirm with the fusion panel. So we've just recently had we've had two relatively recent cases that were each of these. The fusion green was positive on fusion panel. I think it had a cryptic 911, and the fusion red wasn't. It was just a deletion. It's just a deletion that just happens to take out a critical bit of the probe, which is leading to possible misinterpretation. So that's so yeah. Understand how the gene works. Understand which way round your probe is. And that's not easy in itself, is it? We've all got loads of probes and they're not necessarily always easy to remember all of the orientations. And then follow-up testing is so critical in cases like this, like fusion panel. So Nikki, you're talking about lung, so just say the same thing about lung. Exactly the same scenario applies for tyrosine kinase fusions, obviously so important. And ALK is the original generation one that we do, but then the same principle applies to pretty much all tyrosine kinase fusions. It's 5' something else fused with 3' tyrosine kinase gene, such as ALK, but also ROS. They all work the same with the odd exception. So it's the back end of ALK that matters, the far end. And so the far end, ALK on the probes, out with the Vices probe is going this way. Doesn't show it on that Vices map, but it is. So the back end of ALK, the 3', the bit where the tyrosine kinase is, the bit that matters is the red bit. So fusion red is more important than fusion green. And with ALK, there's been so much work on ALK, everybody knows that. There are well-published studies that fusion red is just as biologically significant as fusion red green would be. Yeah, I just thought they're just two useful examples. Just that's sort of like how you work through whether or not an atypical signal pattern is going to be significant. This is just coming back to amplification then, and actually this is just coming back to where I was a second ago when Paul just asked me that question. This is MICN amplification. So that's just a field of interfaces with the site cell MICN probe. So MICN is red, it's amplified in 2 cells, yeah? That's pretty straightforward. It's heterogeneous amplification because there's a load of normal cells. So that's the way you describe that is heterogeneous MICN amplification. So we tend to score in an individual cell by cell basis. That's the key difference of those Ambros guidelines, is you would look at cell and decide whether or not it's amplified. Not. Is this cell amplified or not way of doing it. Clearly 2 are. I reckon on that screen there's 68 cells, 2 of which are amplified. So that's the way I would describe that, as MICN amplified in 2 cells. It's heterogeneous, you know, whether or not that's the same significance as if it was homogeneous, different story. If I was to employ the ratio method, so I've just used the Weaver one, which is from MDM2, but it's pretty much the same, of a ratio of 2. And the difference for me is that you lose your individual cell. You don't think about individual cells. You use the entire field or collection of cells. I reckon each of those is 50. I had a good crack at this. I reckon they're 50. Yeah. So then that ends up with a MICN to control ratio of 1.58 to 1. So that's well short of being amplified. So it's just an example of how different ways that you could score amplification can give you a different outcome. Right. Thank you.
So we've just got a couple of questions from online. Specifically for 1.19Q. So look at Paul there. So do you place the onus on the percentage of deleted cells? So this is what they sometimes do, or the ratio, because like you mentioned in your talk, they contradict each other. So where they contradict, which do you think should be?
Well, I'm more a fan of the percentage really cells, because if they're false positives, false negatives, you can get with just using ratios alone. Complement it with total numbers and percentages.
And that fits what Gavin said about looking at the individual cells. Yeah. And how closely do you work with your neuropathologists when you have those tricky cases? Is that?
Depends where you're based, really.
Yeah.
I think where I'm based in Leeds, the fish work is done between the genetics team and with input from histopathology. It's in the same space. So if it's a difficult case, then the pathologist. And so yeah, those are the cells you need to look at. So I think on the difficult cases, it is really important that you have that relationship if possible. If not, then it creates more challenge. And that integration that Anka was talking about, it works best if you're in the same space. Not in the same space, then I'm not quite sure how you get around that.
Yeah, it obviously depends on the individual setting, but that would be the optimal setup if you can work together.